Okay, thank you for having me. Welcome, everyone. Welcome the candidates. Hope you're having a good day so far. So I'll be fast. I won't bore you. 45 minutes. So let's go just basics on right heart catheterization and stop me whenever you have questions. Especially for first year fellows, that's a big question. For second years and seniors, this may be repetition, but I have some more recent data for you on the later slides, so that so you can get engaged as well. So the to diagnostic catheterization. Common mistakes and pitfalls with hemodynamic measures, when to consider a left heart catheterization for assessing the left-sided pressure, and what are all the indications and how to perform a vasoreactor study. And I think that's where most of the confusion is. What drug to give, when to give, and all those things. So as you all know, we can measure the pressure inside the heart by two methods. One is a standard fluid-filled catheter, which is the Swan-Ganz catheter. The catheter was actually made by a company called Miller. So Miller is called Miller Catheter in general. That's like copy of this machine, Xerox. Xerox is just a company, right? Like that Miller is a company. It makes the catheter. It's called Miller catheter. It has a high fidelity transducer at the tip. So it gives you really sharp, nice tracing. So you don't see any catheter with artifact is much more accurate. And also, like, if you want to do like the increase in pressure over time called the DPDT, which is a measure of contractility, for that you really need good accurate tracing. So you can do those with micronanometer catheter. However, it's not practical for a day-to-day practice. A, it's expensive. Each catheter costs like $400 to $600. So number two, it needs a setup to do that, which itself is like $60,000 to $80,000 if you need the complete data flow. So money is a problem. Three, the technique-wise, like previously they used to have a Miller catheter which can go through the Swan-Ganz catheter. So you put the Swan-Ganz in through your central port where you put your Swan wire, you put this Miller catheter in so you can go to various chambers. Right now, the size of the Miller catheter which they make is bigger than the Swan-Ganz catheter, so it cannot go through it. Now, you just cannot put this wire through because it's just a flimsy wire. It won't go into the pulmonary artery. So then you need to have a JR or a JL4. These are guide catheters, diagnostic. These are diagnostic catheters, then you have to take them into the RV and then do it. So it takes extra time and complexity for a regular clinical practice. It's not very friendly. So this is mainly in research setting. And just to give you a perspective, there was a paper published in Main Circulation Journal on 6 patients with Miller catheter data. So if you have 6 patients with Miller catheter data, which is very good, it's the circulation and quality. So coming back to reality of pulmonary artery catheter, so the pulmonary artery catheter comes in like a 7 French, 7.5 French, and an 8 French. So we put a 7 French venous sheath in the right internal jugular vein, and through that we use any of these catheters. It's 1/10 centimeter in length, and if you see, there are markings here, right? So the markings is the distance between 2 markings is 10 centimeters. And it has a syringe, which is here, which comes with a syringe, and that syringe is a 1.5 ml, and that the syringe is used to inflate the balloon at the tip. Now, it has 4 or 5 lumens based on which company makes it. One is this blue port, is the proximal one proximal one that sits in the right atrium. The yellow one is the distal one, which goes at the tip, which will be wherever you are. If you're just floating in the right atrium, it will be right atrium, right ventricle. If it's in deep end, it will be pulmonary artery. Then you have the other aluminum wire for the thermistor, which is used for the thermodynamic high output. And then you have a white port and extra port, which are only in specialized Swan-Ganz catheters because they're custom made. For patients with pulmonary hypertension, they have really a big dilated right ventricle. Sometimes floating the Swan into the pulmonary artery can be challenging, especially from the groin. So you need to have a stiff wire in it. You can put a wire through this yellow port, but in some patients, patients, it's so hard that we have, like, during my training, we have this custom-made 5/4, which has an inbuilt wire in it, which gives you stability. So that's another option. So how can you do right heart catheterization? All roads all roads lead to Rome. So all the veins will go to the right side. So either you can use your internal jugular veins, either your right or your left, or your common femoral veins, right or the left. Preferably right internal jugular vein, because it's easy for the patient. They can walk out of the cath lab room and go to work the same day. And the pathway it takes this right side is usually easier because it follows a natural curvature. So it's flowed into your internal jugular vein, as we see, right atrium, right ventricle, pulmonary artery. It can also come from the internal jugular axis, not a problem. Now, from the leg, there are multiple ways you can go. One is you can go like the 2 ways, right? This is the most common way. C is the most common way. You go from the femoral vein into the IVC, right atrium, and then you go into the pulmonary artery like this. So what is the common mistake we make? So what people do is when they go in from the right atrium to the right ventricle, they go deep into the right ventricular apex, and they're just trying to just push. It's just getting PVCs, it's just going nowhere. So the key would be just to cross the tricuspid valve, just stay there, wait for the blood flow, just keep going back and forth movement, and then when the balloon pops up, just push, just with the tip. So I think that's the easy method. Now, in some patients, it's very complex. You can do it. So what you can do is you can presume that you're going to come. You can take the path of the right internal jugular vein. So what you do is you go into the right atrium, make a loop. So now once you make a loop, you are now going to follow the pathway as though you're coming from the internal jugular vein. So those are the 2 approaches you can use. These are the common normal tracing for this pulmonary artery catheter. These are atrial tracing, ventricular tracing, pulmonary artery tracing, and this is wedge pressure, which is a reflection of your left atrial tracing. So these 2 tracings look alike. They have a A wave, which is your atrial contraction, which is your V wave, and your X distance, Y distance. You have your right ventricular pressure, you have your systolic pressure, you have your diastolic pressure, and when we say right ventricular end diastolic pressure, it's the higher pressure at the end of the diastole before the systole begins. Not this one, it's this one, right ventricular end diastolic pressure. You have a pulmonary artery tracing. This is your systole, diastole, systolic pressure, diastolic pressure. This is the dicrotic notch. This is the pulse pressure, right? Between your systolic pressure and diastolic pressure. Then you go for your wedge pressure, which is again your A and a V wave. Okay, and when you take measurements for atrial pressure, people always go, okay, what is the A, what is the V, what is the mean? So don't go by the computer-generated mean, because for A, it's actually the mid-A. V, whatever is the peak, is the peak. And for the mean, don't go by the computer-generated mean, because if somebody has a severe TR, their V wave is going to be 40, and the computer is going to average and give you a higher pressure. So what is accepted in the community is the mid-atrial A will be the mean A wave. And that's what I do. So during your right heart catheterization, commonly like when we are in the wards, when people, residents are presenting, they just go haphazard. I think it's useful when it goes systematically. So what is the right atrial? So this is the way we measure the pressure. So right atrial pressure, right ventricular pressure, systolic, diastolic, mean PA pressure. Then we go and wedge, get the pulmonary capillary wedge pressure. We deflate the balloon, get PA saturation. Then we do thermodynamics, cardiac output, index, and then we calculate these variables based on these measurements. How do we calculate this? This is just what is wedge pressure means. How do we calculate it? What is TPD? TPD stands for transpulmonary gradient. This is the gradient across your pulmonary circulation. So it is the difference between your mean PA pressure and your wedge pressure, which is the downstream pressure. So that's transpulmonary gradient. If you divide the gradient by the flow, how much blood flow going through the circulation, the pulmonary circulation, which is cardiac output, then that gives you PVR. And the number you get is in Wood units. And if you want to get in dynes per seconds per centimeter to the power -5, you have to multiply that number by 80. We have to make things complex, then only we can look smart, right? So SVR is always given in dynes per centimeter to the power -5 per second, whereas PVR is given in Wood units. Okay, so Wood units will be like normal, less than 2, 3, but SVR you all know normal would be 800 to 1200 range. So what is the SVR? SVR is the resistance across the systemic circulation, so which is your mean arterial pressure minus your right atrial pressure, which is the flow divided by the flow across the systemic circulation, is the same cardiac output. So mean arterial pressure minus right atrial pressure divided by cardiac output, 800 to 100. So this gives you the normal values, 3 to 5. Your PA pressure is 20 to 30, diastolic 8 to 12, mean is 14 to 20, wedge pressure should be less than 12. Your left ventricular pressure systolic is 120, same as systolic. Aortic pressure, but your left ventricular and diastolic pressure normal is less than 8. We consider anything 15 as within normal limits, but if you truly think less than 8 is the normal value. So what are all the common, so this is all good, this is all normal, right? So what are all the common mistakes made during right heart catheterization? The first and the foremost is failure to level the transducer accurately for each individual case. So this is all, like the pressure measurement is all relative to atmospheric pressure. Right? When I say right atrial pressure is 3 to 6, I'm saying, oh, it's 3 to 6 millimeters above the right atrial pressure. So you have to calibrate your system to atmospheric pressure. If we don't do that properly, then every measurement is going to be affected. And it's just, it's a simple thing, but it's done throughout the world. It's a problem. And as a community, we are not able to come up with standard guidelines because one hospital measures differently and other hospital measures differently. So the pulmonary hypertension heart failure community has now standardized this, and you have to do it at the mid-chest level, which is like 5 centimeters below your sternal margin. Now, this is how do we do it? So ideally, in old days, this is how they do it. They have this caliper, so they measure the diameter of your thoracic cavity. They make you sit here, put the caliper on the chest, measure the chest diameter, take half of that, and then level the transducer in half of the diameter. For example, this is the whole diameter, half of that would be, this is G divided by 2 is half, and you place the transducer at this level. For practical purposes, this is not possible on each and every patient. You take this 5 centimeter below the left sternal border of the fourth left intercostal space. That's the standard guidelines accepted criteria. This gives you an error of like less than 1 millimeter of mercury, so this is okay. So here is just an illustration, like this is normal. You have a pressure tracing. Now let's just play with it. You take the transducer off. When the transducer goes up, what will happen to the pressure? So you will look at all figures below, right? When the transducer is up, it will be falsely high. So so that's number one. What is the second most common pitfall? Is dampening due to air in the system, because this is all transmitter based, right? This is like pressure transmitted through fluid catheter. So the entire catheter system actually is filled with fluid. And if you have air in the system, like it's going to dampen it, and it's going to do false starts. Yesterday we were in patients, like we're doing, like mean PA pressure is 35, so we gave nitric oxide, the pressure came to 10. We were all excited, like, oh my God, this guy has to respond. Then we just go and then see, like it's just dampened, because like we didn't flush the catheter, there's a clot in there, it's dampened, so you just have to think these things, like if you're seeing a huge significant response, it's like, oh, what's wrong? Let me make sure things are okay. So, and when do you start thinking of dampening? Like, your tracing should not be very smooth. If you have a micro nanometer catheter like the Miller catheter, the tracings will be very smooth, sharp. If your tracings are very smooth and sharp, that means there's a problem. That means you're having some dampening effect. It's not like all the catheter, like the motion is not transmitted, and it's a problem. So, the deterioration in frequency response, that means like fancy term, but if it looks very sharp and dampened, then think of air bubbles, either anywhere in the catheter, stopcocks, tubing, flush it, make sure you're okay. The other problem with the Swan-Ganz catheter will be catheter whip artifact, because the catheter goes inside and it's like moving with every heartbeat, tachycardic, when the patient is tachycardic, the catheter is going to go move up and down. And that's going to produce artifacts, and that's going to give you a false value. So when you just look at the computer-generated values, that's going to calculate based on the artifact. So you don't want to take the mean. You want to look at your own tracings and just do that. Okay, so this is called the dampening phenomenon. So this is normal would be like this. So you see some what do I say, wave reflections. If you see this like completely smooth lines, that means it's over damped. If you see a lot, it can be under damped. So if you are really like under damped and you're seeing just so much artifact and you're not able to see, what you can do is you can get some heme in the line or blood in the line. Blood is viscous, so it dampens it to your artificial vibration to less than extent. If you take too much blood, you'll be over damped, so you just have to be careful. So the next third common pitfall is like making measurements at different parts of the respiratory cycle. You want to make best way to measure or more accurate way to measure. So here is your wedge tracing. So you have inspiration, expiration, inspiration, expiration. What the computer gives you a mean, but what the computer does is it takes based on the system, either 15 seconds or 30 seconds or 5 cardiac cycles, whatever you program the computer, it will take the average wedge pressure over the time and give you the mean. This is not actually a right way to do that. You have to do the end-expiratory pressure measurement. So which is like you manually look at it and take this pressure measurement at the end of expiration. This is your inspiration, expiration, end expiration, take this pressure measurement. Okay. Why is this important? Because I'll show you some data. So this is like, I think you guys have already looked at it. Like this is 61 patients referred for evaluation PH at the University of Chicago. They had both right and left heart catheterization at the same time. So what we did was we compared the computer-generated pulmonary capillary wedge pressure and also the manually calculated end-expiratory pulmonary capillary wedge pressure to left ventricular and diastolic pressure, which is the gold standard, right? The pulmonary capillary wedge pressure is the surrogate for your left side diastolic pressure. So when we did that, you can see the pulmonary capillary wedge pressure by the computer, which is the digital one, is much lower than your actual LVEDP. Your end-expiratory measurement actually correlated close to your LVEDP. That's because you can see here, your computer-generated pulmonary capillary wedge pressure underestimates your batch because it takes the inspiratory value, which is a lower value too. So you can underestimate your pulmonary capillary wedge pressure just by relying on the computer once. Okay, so the next one is overestimation of pulmonary capillary wedge pressure. Your wedge pressure may be only 10, but you may be giving a false value of 30 to your clinical virus. And why is that? That's because when you have severe pulmonary vascular disease, you're small, like normally when you're wedging, you're going to the capillary level, and that's when, like just before the capillary, you're dilating the balloon and going to that level. But when you have pulmonary arterial hypertension or intrinsic pulmonary vascular disease, your small pulmonary arteries are remodeled and the lumen is so small, so you can't even get to the pre-capillary level. So you will be at a distal pulmonary artery branch and like wedging there. So you're actually getting a PA pressure, a partial PA pressure, rather than a left atrial pressure. Because if I have to go back on this slide here, so basically this is what the wedge pressure does. Like, this is your vena cava, right atrium, right ventricle, pulmonary artery, and before this is capillary. So before the capillaries, you wedge here, so that the balloon, what it sees is that there's like this lumen is between the left atrium and the balloon. So that reflects, the pressure is reflected from the left atrium. However, if you have severe remodeled pulmonary artery vessels, you may not be able to cross this point. So you may be just wedging here. So what you're actually getting is the pressure in the distal pulmonary artery, which is like a partial PA pressure. Right? So you could be, instead of the wedge pressure is 10, you could be giving a wedge pressure of 30. So how do we differentiate that? You look at the waveform. So how would this go? So before you call, and this is an example of, this has been demonstrated. So let's say, and this is very common in patients with PA heights. In normal patients, you will get it. Why? So your diastolic PA pressure, which is your systolic PA pressure, diastolic PA pressure, and your wedge pressure should be here, meaning your wedge pressure cannot be higher than your PA diastolic, right? Blood will then go backwards. So your PA diastolic has to be equal or higher. In a normal person, what happens is if you partially wedge for some reason, the wedge pressure will be higher than your PA diastolic. So then your antennas will go up and say, oh, that's not physiologically possible, so I did something wrong. However, in PAH, you can be easily fooled. Why? Because of their vascular remodeling, their PA diastolic pressure is very high than their wedge pressure. So you have a huge gradient. So even if you partially occlude, your wedge pressure will be lower than your PA diastolic. So you'll think you're okay, but you're actually not okay. You see, you should actually, here the gradient you're giving is only like 2 or 1 millimeter to the reference provider, but actually the gradient is actually more than you want. It's like 10 millimeters. And this is what they did. So this is normal tracing, PA, with 1.5 ml of balloon. They inflated their vent in. They started tracing. They called this as a wedge tracing. They checked the wedge stat, but it's only 89%. What they did was, to get a true wedge, they deflated the balloon, and now they went with half a balloon, because now with half a balloon, you will be able to navigate the small lumen and go distal. And when you're able to do that, this tracing looks more like atrial tracing, right? This is like in between this is your PA, this is your atrial tracing, this tracing is actually in between. So this is your true atrial tracing, and you confirm it with a wedge that is 97%. So that's your pressure measurement. So at the 1.5 ml, they gave a PA wedge pressure of around 23. They take half a balloon, it actually came down. Same thing for 2 patients. So this is another example. So here is your the wedge pressure or illusion. So this is how much is your wedge pressure right now? The wedge pressure right now is close to 25, right? Roughly. They're getting 27. So they get on oximetry, it's 82%. The operator is very anal, like me, 6. So what he says is, okay, I don't like this. So he goes with half a balloon or 1/4 of a balloon, more anal than me. So this is actually Paul Fortia's site from UPenn. So I have to give credit to him. So he then remeasures the wedge pressure. Now the wedge pressure is what, like close to 11 something, and the wedge saturation is 98. So it just takes the extra, time. Why is this important? Yes, sir.
How far do you pull back towards the main PA before you pull the balloon down, and then, because I mean, you just drop it to a quarter, it could shoot out quite a bit further. You pull it back in, drop it down to a quarter balloon, and then slowly advance forward, or you just drop it in place and let the blood get it out into the periphery?
Perfect. So over time, like, from different people, the technique I learned is, so you go with the balloon, okay? Push. You're wedged now, okay? And then you get this tracing, you're not happy. What you do is keep pushing slowly, gently, till you form a slack in your swan gland catheter. Once you have a slack, and now you deflate the balloon, it will just stop deep in. Once you are deep in, you have to be extremely careful. That's why you just don't go inflate your balloon. Boom. Then you're going to rupture the capillary. Very slowly, with 1/4 or 1/5, inflate your balloon, and then like you will beautifully see the wedge tracing coming down. So the key is, when you push, just keep pushing slowly till you form a slack. Deflate the balloon, you're okay to dive deep in. When you're re-inflating, be careful and very, very slow. Okay, don't go fast. That's when you rupture your pulmonary capillaries, send the stroke. People die. So now, hopefully it doesn't happen, but I'm just saying it can happen. You just have to be careful. Okay? You don't keep doing it. So now, why is this important? This is from a referral center. This is actually from Dr. Scott Halpern at University of Pennsylvania. So he took all the patients, 3,900 patients in their cath lab who was referred for PH. So he took this to patients LVEDP. All the patients got left-sided pressure measurement and swan gas catheter. So then he plotted. So here is the scatter plot correlation. So if you take this box, their actual LVEDP is higher, right, which is the gold standard. But the reporters reported a low wedge pressure. That happened in 50% of the people. So their wedge pressure is actually, their LVEDP is actually high, the wedge pressure is low. So what is the reason for this? Why did they make the mistake of giving a low wedge pressure? They did not measure the end-expiratory. They just went by the computer-generated mean, which is the lower wedge. If they went by the end-expiratory, it would have been higher, which is correlated with LVEDP, which is a common practice, right? We don't look at it and say, oh, the computer generated text captures it, move on. Now, partial wedging, which is not that common because PAH is not a common disease, right? It's a rare disease. So in 4.5% of these patients, their wedge pressure they reported is actually high. They reported that the wedge pressure is more than 15. In fact, their LVEDP is low. So this is due to the partial wedging or overestimation of your wedge pressure in patients with PAH. Why is this low? Because PAH incidence in a run-of-the-mill cath lab, if you do 1,000 caths, right, left heart disease is going to be much more common than your PAH. So these two things can lead to misclassification. So these patients, in fact, had left-sided heart disease because their LVEDP is high, but they're labeled as Group 1 PAH and started on therapy. More so, sadly, these patients who have actually pulmonary arterial hypertension are labeled as Group 2 and deprived of a life-saving therapy. So, or can't strongly say life-saving therapy, at least quality improvement. How to be fair. Hypoprosternal is life-saving, survival proven, 6-minute walk distance. That's true. But hypoprosternal do improve survival. So is wedge pressure a good principle? Yes, of course, but with the caveat that we do properly. So inaccurate measurement is very common in day-to-day practice. There's difficulty in wedging in patients with PAH, right? It's just false. And it can be false. And the last thing is, sometimes when you have severe PAH and your right ventricle completely fails, and it's not able to generate a cardiac output to create a forward flow, the wedge pressure is going to be low because that's like being dry. Like the pulmonary circulation is dry because the RV is failing, not able to generate the output, so your wedge pressure can be possibly low. So what is the best wedge pressure? You should your pulmonary capillary wedge pressure should always be lower than diastolic. That's nature, physiology. You can't report a higher wedge pressure. That means you can take your coffee that day. So when you do the balloon inflation, you should have a good normal waveform. You should have a good A and a B waveform. If you're not happy with the waveform, go back, get back. If the baseline is creeping upward, that means like sometimes you have a wedge pressure and then like it just starts going up and up and up again above your diastolic. That sometimes can happen when you are deep in an over wedge. So don't do that. And if you go on Pluto, when you're taking a wedge pressure and your balloon is inflated and wedged, it should not be just popping. It should be stable, stationary. If it's just popping, that means you're not completely wedged yet. Then correlate, the gold standard is correlate with your oxygen saturation, but it can be sometimes very difficult to get oxygen saturation for patients with PAH because their vessels are remodeled and you don't have any space to get the blood through the balloon. The balloon is completely occluded. Left heart disease is common, but PAH it can be a problem. And you have to make all the measurements again, end-expiration. Having said all these things, so this is very, very, very important again because the differentiation between these two categories of PAH and PHFS depends on this measurement of wedge pressure. Because anybody who has more than 25 mean PA pressure is considered pulmonary hypertension. But if their wedge pressure is less than or equal to 15, they are considered Group 1 or PAH. If their wedge pressure is more than 15, it's considered as Group 2. And if it's just classification, that's okay. But the prognosis changes, treatment changes, completely everything changes. So take extra precautions to do that. And as I said, wedge pressure is good, but there can be some problems. Here's your mean capillary wedge pressure and left atrial pressure, and these are patients with left heart disease, valvular heart disease. You can see this was published in 1973 in American Heart Journal. There is a good correlation between these two. So it's a good surrogate if it's taken properly, but can be a problem when the wedge pressure keeps going up. At a higher pressure, the discrepancy can be higher. I'll explain why. For now, I'm going to skip that. So if wedge pressure measurement is important, but if you're not able to get, occasionally you won't be able to get a good wedge pressure. And for those patients, I think it's important to go on to the next level and just do an LVEDP, which is very simple. Because nowadays, radial catheter, they can still go home with a PR band, with a full French diagnostic. The other day we were in the lab, we just couldn't differentiate, and we said, okay, we call the interventionalist, Alan helped me, we put radio, and then we just went in and just did the LVEDP. If your leg, I do myself, radial, I get but like that, you just have to take the extra steps and get the answer. So the teaching is, don't come out of the cath lab without an answer for your patient. And, would you come out from a coronary angiogram without knowing what is the lesion? And if you have questions, we're going to put an FFR and do an FFR and study the lesion. That you need to know exactly what is the answer for the patient before you come in. So if you have a problem, suspect if there is an inaccurate wedge measurement, then go for it. For example, classic example is, you have somebody who's like 78 years old, who has like diabetes, hypertension, LV systolic dysfunction. You're calling the pulmonary capillary wedge pressure at like 15. In those cases, by epidemiology, left heart disease is more common than PAH. Suspect with 2 pH in those, go for an LVEDP measurement or some other maneuvers, like either you do volume to them or exercise them and see the wedge pressure goes up. At least this should be done during the LVEDP measurement, should be considered during the first time diagnosis. During follow-up, yes, sir.
So what is your take about using the PA diastolic pressure as a surrogate for LVEDP? Because the argument is based on
So here is the answer to the question, right? I don't know, it depends on the vessel remodeling. Your PA diastolic is not going to be a surrogate of LVEDP if you have an intrinsic vascular remodeling. If you don't have any vascular remodeling, your pulmonary vasculature is completely normal, yes, they're going to correlate within like 5 millimeters difference. But if not, there's going to be a huge variance. In PAH patients, your LVEDP will be 10, PA diastolic will be 40. You're not going to use the PA 40 as your LVEDP, right? So if you have an intrinsic pulmonary vascular remodeling, then that gradient increases. So I have a few slides in the back. So the other common question comes in, because I think interventionalists believe that, which is I think true to some extent, is, oh, you have severe TR. When you have severe TR, thermodilution cardiac output is not reliable with the patient's PH. So I'm not going to do thermodilution cardiac output. It's going to take time to do it. But in fact, there is clear evidence in PH patients, thermodilution cardiac output correlates in general. There can be some exception patients where your severe TR is extremely severe, can correlate. But in general, it is a useful measure and it should be done. This is Marius Cooper, who is a very well-reputed investigator from Germany. What he did was, he took PH patients, he measured thermodilution cardiac output, and then actually did actual peak cardiac output, which is the gold standard, not even the estimated. And then he compared the both at different levels, in patients with low output, high output cardiac output, patients who have mild to moderate TR, severe TR. And you can see, this, more the difference, you'll be away from the central line, right? So here, under various conditions, low output, high output, mild PR, low PR, you're close to the line. There's not much difference between these two methods. So thermodilution is valid in patients with PAH. It's not an excuse not to use it because of it. Okay. So moving on now, once you have this, what do you do with the vasodilator study? That's where so much confusion happens. So just broad strokes. Vasodilator studies are done for different reasons in different settings. In patients with PAH, or group 1, which is what I deal with, the reason to do a vasodilator study is to see whether I can treat them with calcium channel blockers or not. If they vasodilate and I give them calcium channel blockers, their response, their survival is pretty good. Here's the data. So this is from 1994. Patients were given calcium channel blockers, and they can observe whether their pressure comes down acutely. If their pressure comes down acutely, they were given calcium channel blockers. If they are not, they are treated conventionally. Patients who are treated with calcium channel blockers at 5 years, 16 months, their survival is 92%. If you don't respond and you're treated with conventional therapies, their survival is close to 35%. It's a huge difference. And this is a different phenotype. These patients, they just have pulmonary vasoconstriction. And you identify them early and treat them properly, you have better prognosis. And this is not much. It's only 5 to 10% of your patients with idiopathic PAH. Okay, that's the main purpose. We do vasodilator testing in PAH. So when is that? When you go in the cath lab and the mean PA pressure is more than 25, that means they have PAH. When you look at their wedge pressure and their left pressure is less than 15, that means they don't have group 2, they have either group 1 or group 3 or group 4, group 4 or 5. But if they have group 1, then we usually, most of the time, even group 3 we do it, but we don't treat them this way. We give them vasodilator testing. We give nitric oxide, different protocols, different places. Our protocol is 40 parts per minute for 3 minutes, and then we go to 80 for 5 minutes, and then see a response. Other drugs we can use are IV adenosine and IV epoprostenol. In our lab, we don't use it, so don't get confused. We go with nitric oxide. So what is the response? The response is your mean peer pressure should fall by 10 with an absolute value less than 40 within the presence of an unchanged or increased cardiac output. Example, if you start before the vasodilator testing, your mean peer pressure is 60. You do the nitric oxide, your mean peer pressure comes to 35. So that means your absolute value is less than 40, and you're dropping by more than 10 because you're dropping by 25 millimeters of mercury, and their cardiac output did not change. Then that's a response. How do I know that? This is also data from a French group who looked at, like they did, they collected data, like they did nitric oxide on every patient they saw for 15 years. They went back and looked at which patient actually lived longer, and patients who satisfied these criteria lived longer. This is not based on 2,000 patients, it is based on 450 patients data. But it is, PAH is a rare disease, and that's what is accepted. Like I said, this is very, very small proportion of patients, 5 to 10%. And there are some believers, there are non-believers. Dr. Brisker is kind of a non-believer a little bit. But I have seen myself patients in my training, like, who are completely healthy just on Norvasc 10 milligrams or 15 milligrams for 20 years with a normal PA pressure of 60, now normal is 25. So if you really identify the right patients, they do respond. So if they respond, you try them calcium channel blockers. If they don't respond, go for other conventional therapies or fancy therapies. They call the PA specific therapies. Now, what if your wedge is this now?
Why in group 3? I mean, we've gotten into the debate before in the cath lab. Someone was coming for a long transplant. I understand from the cardiac side, you need to make sure that your RV can tolerate, that the transplanted RV can tolerate the increased resistance. But if you are looking for pre-transplant or other parenchymal lung problems, what is the benefit of doing vasodilator therapy?
So, is there data to support vasodilator testing in group 3 or group 4 PA? This is math questions. No. If we do a patient with COPD or interstitial lung disease, and we give nitric oxide and if they have a response, by using calcium channel blockers, will they live same 92% survival like the PAH group? No, we don't know. Okay, we are just collecting the data, like maybe a French group, and 50 years from now, we may see some, response. So we are just doing as a protocol for completion sake. Does it have any clinical, meaningful value at this point? No. We don't base our judgment. Sometimes, Mark and I would say, hey, we gave the main reason we give nitric oxide, to be honest, in group 3 is sometimes it's even worsen the VQ mismatch. We can make them more hypoxic. So if I give nitric oxide in the lab and they're getting hypoxic right there on the table, I'm not going to give them PA-specific therapy. PA-specific therapy, I don't want to go there because it's an unapproved indication. Sometimes we go off-label use, and for that, we just want to check, okay, is this at least tolerated? The corollary is not true as well. If they tolerate it, doesn't mean that they're acutely, doesn't mean that he's going to tolerate chronically. They're different, but we're just trying to see these things, phenomena in the future. Now, if your wedge pressure is more than 15, then you're going completely on the left side, right? There's a reason for the vasodilator study is to see whether the pulmonary hypertension is reversible or not. Why? If you're going to go for a transplant, if you have severe fixed irreversible pulmonary hypertension, the graft right ventricle is going to fail right away. So to avoid that, you want to make sure that the pulmonary hypertension is reversible. That's why you do reversibility testing. And the common drug we use is nitrite. And what is the phenomenon? You give nitrite, you decrease the systemic vascular resistance. When you drop the systemic vascular resistance, wedge pressure drops. The wedge pressure drops, pulmonary pressure usually drops if it's reversible. If it doesn't drop, it means it's irreversible. And how do we do that? We start nitrate at 0.25 micrograms, increase every 3 minutes, and we stop it at pressure drops to 25, I achieve my goal, right? I said it's reversible. I don't need to go any further. Or if my systolic blood pressure is less than 90, there is no point in me saying, oh, the systemic pressure is 50, the PA pressure is low. That's meaningless. So if you stop at 90, that's good. I actually, when I wrote the protocol, I just pushed for 85, but Bob let me do it. So 90 milligrams. Or any, even if they are 110 or 100, if they are symptomatic, usually they are not symptomatic because they are in the table and they will be fine. But if they get really symptomatic, you do it. Or if you reach a max dose of 5 micrograms, it's a very high dose, and you stop right there. This is for us, or for you fellows to think, it's like, okay, if somebody's blood pressure is really less than 15, but they have all these risk factors, right? They are 80-year-olds, they are diabetic, hypertensive, severe thick LVH, all the prototypes for diastolic dysfunction, group 2 pH, but their wedge pressure is less than 15, don't call them as PAH. Try to maneuver, do some maneuvers and really see what happens to wedge pressure. Simple thing would be to give them volume, 500 ml of saline over 5 minutes. That's not a standard protocol. That's a problem in the field. But 500 to 1,000 cc's over 5 minutes to see what happens to wedge pressure. If the wedge pressure comes high, like goes up from 15 to 25, you know the answer. This is just not group 1. Now, the other thing you can do is exercise. If you exercise them and the wedge pressure goes up, then you have fat, and diastolic dysfunction. Which one is better? Barry Mayo would say exercise is better. He believes exercise is better, and he has data to show that. And group in Nashville, Tennessee would say, no, volume is okay, and not every lab is going to have an exercise spike. So we have both based on the circumstances we use. Went over this, we went over this, went over this. Okay, just for sake of time. Now, what transformer gradient and PVR? So do they reflect pulmonary vascular remodeling? Meaning, like if somebody's PVR is high or transformer gradient is high, does they mean that they have intrinsic pulmonary vascular remodeling, right? When the PVR is high, we all think they have. It's actually not true. So these are data actually reviewed from patients, hemodynamic data from human patients with various disease. This is a correlation between your mean pulmonary capital wedge pressure and pulmonary artery diastolic pressure. So your pulmonary artery diastolic pressure and wedge pressure actually correlates really well. That's one thing we know for sure. But the systolic pressure, PA systolic pressure and mean pressure does not correlate with the wedge pressure. And these are not just, these are schematic diagrams, but the data is obtained from patients from various data sets and pooled together. If you take the x-axis, this is your wedge pressure, and y-axis is your pulmonary artery pressure. Right? At a mean wedge pressure of 10, your PA diastolic is 10. If you go to a wedge pressure of 20, your wedge pressure, PA diastolic goes up accordingly. It doesn't go beyond 20. It just maintains the gradient between your diastolic PA pressure and wedge pressure remains the same. As you go up here, it goes up linearly here. Whereas your systolic PA pressure disproportionately goes. See here, at 10 millimeters of mercury, the gap, the pulse pressure here is close to what, like 12 or 15 millimeters of mercury. Whereas at a high wedge pressure, the PA systolic inappropriately goes up, or out of proportion goes up here. So your PA pulse pressure significantly increases. So if your PA systolic pressure goes up, diastolic pressure remains the same, or so. Your mean PA pressure is going to go up, right? Mean PA pressure is calculated from your systolic and diastolic. If one goes up, your mean PA pressure is going to go up. If your mean PA pressure goes up, your transpulmonary gradient is going to go up. So at higher wedge pressures, you can have a high transpulmonary gradient just because of the high wedge pressure. And why is that? When you have a high wedge pressure, there is not much room for the forward flowing cardiac output. So the vessels have to get distended, and when they get distended, the PA pressure goes up higher. They get much more stiffer. So there is movement in the community not to trust TPG and PVR for intrinsic pulmonary vascular remodeling. So then what is the alternative? So what we are adopting now is the diastolic pulmonary gradient. What is diastolic pulmonary gradient? It's the gradient between your PA diastolic pressure and your wedge pressure, right? So we have a question, can I use it? Not in all patients. Here's an example. This is based from a group in Vienna, like 2,600 patients, cath lab data for all patients referred to heart failure. They fortunately got autopsy samples on some patients and correlated their hemodynamics. When you have a left heart disease and a normal transpulmonary gradient, you see this pulmonary artery, the red is lumen, blue is wall thickness. The wall is not that thick. You see this arrow, it's very small. Whereas if you have a high TPG, whereas DPG is normal, your wall is thick but not very thick. Okay, this is thickness. See this artery here? You see the lumen, see the thickness. This is what when I say intrinsic pulmonary vascular remodeling is. When you work on, I worked on animal models, like you give monocrotal into animals, you see this thick arteries. This is like cancer. Your muscle, smooth muscle cells in the pulmonary artery proliferate and they really get thicker. And when you have such thickness, see the diastolic pulmonary gradient in these patients is high, and the transpulmonary gradient is significantly high. So the diastolic pulmonary gradient correlates with, it's not perfect measure. There are other factors which can affect it. To some extent, it's a good correlation to intrinsic pulmonary vascular remodeling. And this is the thickness in patients with pulmonary arterial hypertension. You can see here how thick the artery is. This is so thick, the lumen is so small. Here you don't even see the lumen, the fluid. This is called the angioperitoneation. So now more and more we are saying diastolic pulmonary gradient would be a surrogate. I'm not saying it's a perfect surrogate for advanced pulmonary vascular remodeling. And I say remodeling, this is the thickness. However, there is controversy in the society that whether the DPG is a prognostic factor. If you have a high DPG, would it reflect bad prognosis? This data would say yes. So these are patients with no pH. Compared to no pH, patients with whatever form of pH did worse. However, within pH, if you take this is people with high DPG, low DPG, there is no difference in their survival. Sorry. There is actually, in this data, there is difference in survival. Here this is DPG less than 7, this is greater than 7, so compared to more than 7, less than 7, this is kind of worse survival. And this last line is your PAH. So PAH has the worst survival. The people who don't have PAH have the best survival. When you have left heart disease, when you have passive PAH, with your TPG and DPG are normal, you have a better prognosis. Then you separate them by DPG. If you have a higher DPG, you have a worse prognosis. Normal DPG. Whereas this data has not been reproduced in other data sets. This is analysis from UNO's database of Pitfalls. What he did was these are patients listed for transplant, and then he looked at the DPG because every patient was listed for heart transplant, get their baseline right heart cath data entered into the database. He used that to see whether it predicts prognosis. And he can't see a difference in survival. Whatever the cutoff he uses, guidelines is 7. He used 3, 5, 7, 10. Couldn't do it. But the downside of this paper is there is a selection bias. When you're listing someone for transplant, you are not going to select someone who has significant intrinsic pulmonary vascular disease. So, and also these data are computer-generated data. These are not manually reviewed data. So, people would say garbage in, garbage out. So, can you really trust that? However, so Ryan didn't let go. He said, okay, I'm going to go to Johns Hopkins database, not transplant patients. These are myocarditis patients with cardiomyopathy who had like hemodynamics. I'm going to look at the survival based on DPG. He couldn't see a difference. No pH differentiate people, but within pH group, different DPG levels did not pan out. So I think we don't know yet whether DPG is a marker of prognostic factor, whether it's a prognostic marker, but it is a marker for intrinsic vascular remodeling. So I was telling Darren yesterday, so take an example, EF. Is your EF a prognostic factor? The first answer would be yes. Yeah, a low EF means like people will die sooner, but that's in all comers. If you take heart failure patients, a low EF or high EF, in other words, heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, your prognosis is the same, right? Your survival is the same. Data from Mayo Clinic, Holmes County, data from Canada, beautifully shown. The landmark papers in Dr. Westfield. Two goes overlap. So EF is not a prognostic factor, but it does help to differentiate the pathology because the treatment is different approaches. So I think that's fair. I'm going to stop there. Don't do it anymore. Okay. Question. Oh my God. I'm completely sleepy. Good.
I have a question.